Good morning and warm welcome to Online Anaesthesia Postgraduate Teaching Program on Zoom platform sponsored by Acrola and hosted by A1 Logics and simultaneously aired by Anaesthesia TV. Today they have a technical problem in Anaesthesia TV, so it will be rectified in the afternoon. Meantime, you can access your YouTube link in our chat box. It is given in the chat box. Today we are starting the pediatric anesthesia series. We have two eminent professors among us in this session. The first topic is preoperative evaluation and preparation of pediatric patients by Professor Shanti Palraj Madam. The second topic is the cardiorespiratory physiology of pediatrics, Professor Dr. Mala. So today's session is coordinated by Dr. Shantini. Over to you, Shantini Madam.
Good morning, sir. Good morning, one and all. I welcome our first speaker, Professor Dr. Shanti Palraj, to enlighten us on the preoperative evaluation and preparation of pediatric patients. She is presently holding the post of HOD and Professor, Department of Anaesthesia, Tanjavur Medical College. She is a pediatric anesthetist and a life member of Indian Association of Pediatric Anesthesia. Her areas of interest are pediatric laparoscopy. She has been speaker in many conferences and CME and has many publications in Indian journals. Welcome, ma'am.
Thank you for the intro. Good morning, one and all. The topic assigned to me is pre-anesthetic evaluation and preparation of pediatric patient, one of the most important topics for the postgraduates. Over to the topic.
Sure. Yes, madam, it's visible. You can go.
Yeah. Okay, sir.
So make it full screen. Okay, now it's.
So though pediatric age group is defined as all children from birth to 12 years, below 12 years in Indian setup, the international definition says that pediatric age group includes from birth to 18 years of age. So these adolescent pediatrics will be shortly included in the pediatric age group in the Indian scenario also. So the different pediatric age group ranges from the newborn, the neonate from birth to 28 days of life, the infant from 29 days to 1 year, the toddler from 1 year to 3 years, the preschool children between 3 to 6 years, and adolescent school going between 6 to 12 years, and adolescent between 12 to 18 years. Pediatric anesthesia is inherently risky because of the varied age group of children and who have a different physiological and psychological makeup, and the anesthetist should approach from each age, approach each one in a different approach. Coming to the aim of pre-medication, the aim of pre-medication is to assess the child's general condition, to look for the presence of acute and chronic intercurrent illness, preoperative anesthetic problems, estimation of anesthetic risk, and to formulate an anesthetic plan. It also should take into consideration the needs of the planned surgical and medical condition and the psychological content of the child and family. The pre-anesthetic evaluation is the most important aspect of pediatric anesthesia. It starts with the pre-op visit. It is the responsibility of the anesthetist and the opportunity for the anesthetist to learn facts and to win confidence of the parents by a pre-op visit. It should be done at least 24 hours before the planned procedure and preferably by the anesthetist who will be anesthetizing the child. The pre-op visit will go a long way in decreasing the parental anxiety and increase the parental satisfaction. Coming to the steps of pre-anesthetic evaluation, it includes the history taking, the physical examination, the review of medical records, evaluation of laboratory, radiological, and other investigation, assessing the emotional status of the child and family, and optimization of perioperative medical therapy. Pre-op anxiety. Pre-op anxiety is the most important psychological aspect to be dealt with. Here, not only the patient is anxious, but also the parents are anxious. And the next person to be anxious is the anesthetist. So the parent, the child, and the anesthetist all are anxious because pediatric anesthesia, everybody fears pediatric anesthesia because of the risk of acute morbidity and mortality during anesthesia. Pre-op anxiety may affect emotional and intellectual development of the child, and the parental separation is the most stressful experience of the child in the hospital because the child is taken away from the comfort zone of the home. In addition, the pre-op anxiety is an independent predictor of post-operative negative behavior. The negative behavior includes stormy recovery, irritant and violent child, emergence delirium, etc. So though we talk about pre-op anxiety so much, there are not much scales to evaluate the level of pre-op anxiety in pediatric age group. Coming to the history includes an array of history taking like birth history, past history, family history, treatment history, immunization history, history of genetic or congenital diseases, allergic history, and bleeding diathesis. The history which is unique to the pediatric is birth history, which includes the history of the delivery, whether it is full term or preterm delivery, whether there is history of congenital defects, whether there was NIC admission, the indication for admission and the outcome of the admission, etc. And immunization history is also important in pediatric age group. The other important history is history of genetic or congenital diseases. In the history, one should elicit the history of any intake of herbal medications by the pediatric group of children. The anesthetic significance is these herbal medicines may interact with the anesthetics, may alter the heart rate and BP, may produce hypoglycemia and cardiac abnormalities. In the chronic ingestion may also lead to hepatotoxicity. It may potentiate the sedative effect of anesthetics, and in some cases, it may decrease the efficacy of anesthetic drugs. The physical examination includes general examination and system examination. The general examination in pediatric includes the gestational age, the height, weight, the head circumferences, the cry, activity, color, and the temperament of child in the pre-op assessment. System examination should consider the gestational age and weight during examination. Coming to the cardiovascular system, if the history suggests any indication of congenital heart disease like failure to thrive, feeding difficulties, diaphoresis, etc., you should look for murmur. And in a known case of congenital heart disease, you should look for signs of congestive heart failure. Likewise, in the respiratory system, you have to note the rate and pattern of respiration, whether the presence of URI, LRI, Bs or abnormal sounds like snoring and croup. In the CNS, take into account the cognitive status of the child and its any factors which point to developmental delay. In the GIT, look for jaundice and any features of gastroesophageal reflux. Hematological systems include signs of anemia and history of bleeding diathesis. Muscular and neuromuscular diseases are also important, and you have to look for any congenital disorders in the child, including myopathy. Difficulty airway. Assessing the difficulty airway is difficult even for the anesthetist in pediatric age group. So the difference between adult and pediatric is in pediatric age group, there are not definitive indicators, but one should look for specifically the head, face, and neck anomalies to get some clue regarding the difficulty airway. Head anomalies like hydrocephalus, facial anomalies like cystic hygroma, mouth and anomalies like microstomia, nasal or palatal abnormalities like palatal defects and adenotonsillosis, laryngeal and tracheal anomalies like laryngomalacia, tachomalacia, and neck and spine anomalies, example, congenital cervical instability in Downs and mucopolysaccharidosis. The syndromic child is a challenge for the anesthetist. So a lot of syndromes are there, but the knowledge of the particular syndrome presenting us should be thorough for the anesthetist to handle this syndromic child. The the most of the syndromes here are depicted here have airway problems and airway anomalies, which pose a difficulty for intubation, like Albert's charge, golden hair, mucopolysaccharidosis, Pierre Robin, Treacher Collins, Down syndrome, etc., etc. The pediatric assessment of airway includes, as I told, history of snoring, daytime somnolence, stridor, hoarseness of voice, difficulty in feeding, nasal congestion, then a prior surgery of the face and neck. In addition, you have to review the previous anesthetic records and surgical records for any indicators of difficult airway. Examination of difficult airway includes size and shape of the head, face, symmetry of the mandible, presence of submandibular pathology, size of the tongue is important, whether there is macroglossia, shape of the palate, the prominence of upper incisors, the range of motion of head and neck and jaw, presence of cyanosis. And in the age group of 6 to 12 years, look for loose deciduous dentition teeth, very important. And in the respiratory system, look for the presence of chest retraction and abnormal birth sounds. Predictors of difficult airway. The difficult airway in pediatric age group, unlike in adult, none of the tests have been extrapolated to pediatric age group. So it is not very easy to predict difficult airway in a child. Only there are some signs which will give a clue to the difficult airway, and no authenticated tests are available to predict the airway. So Mallampati class and mouth opening are not predictors of difficult intubation in children below 18 months. The modified Mallampati can be used in the age group of 5 to 12 years. So the common predictors used in adult have a varied sensitivity and specificity in the pediatric age group. But in older children, the following predictors are good, like mandibular protrusion, atlantoaxial mobility, mandibular space, and tongue thickness. So as an adult, the child may have a difficult mask ventilation, difficult intubation, or difficult SGE placement. Overall, the risk factors are infant less than 1 year, ENT surgeries, congenital and acquired anomalies of the head and neck, and obstructive sleep apnea. Smaller the child, difficult the airway. So whenever the anesthesiologist is faced with the difficult airway, he has to thoroughly examine the child before venturing an intubation. These are some of the examples: cleft palate, micronatia, meningomyelocele, hydrocephalus, mandibular hypoplasia, Down syndrome, mandibular cleft, etc. There are some specific concerns in pediatrics. The difficult airway gains much significance because it causes acute morbidity and mortality in the pediatric age group. Some of the specific concerns are obstructive sleep apnea because of the altered response to carbon dioxide. The child with development disability like autism and cerebral palsy may have behavioral issues, a poor cough reflex. Preterm and ex-preterm babies are a special group of population in the pediatric age group which needs much care because there is a risk of apnea in the post-operative period. So less than 56 to 60 weeks of premenstrual age babies are more prone for apnea. Child with congenital heart disease, child with difficult airway, like hypoplasia of mandible, hyperplasia in Hurler's and Hunter syndrome, and child with metabolic disturbances. This is often encountered in practice, like pyloric stenosis and intestinal obstruction, where the metabolic derangement like hypokalemia or any other metabolic disturbances should be corrected before taking up the case for anesthesia. Neural tube defects like spina bifida, meningomyelocele, neuromuscular disease like myopathy. The significance is in the case of neuromuscular disease, the patient may have a sustained contracture, may be prone for hyperkalemia and malignant hypothermia. Vaccination and anesthesia. We may encounter a child who have been recently vaccinated. Is there any significance for anesthesia and vaccination? The recommendations are appropriate delay between vaccination and anesthesia is recommended to avoid misinterpretation of vaccine-associated adverse events in the perioperative period. So For inactivated vaccine, it's better you schedule the surgery 2 days after the vaccination. But for the live attenuated vaccine, it's preferable to schedule 7 to 21 days after vaccination. Coming to investigation, unlike adult, the only consolation for the pediatric anesthesiologist, we do not need a battery of investigation like adult. So routine investigation include hemoglobin, bleeding time, clotting time, platelet count, and urine complete. Specialized investigations are needed only if indicated, like blood sugar, complete blood count, blood urea, creatinine, electrolyte, serum bilirubin, coagulation profile, and grouping and typing for major surgery. Chest X-ray is not mandatory in pediatric age group, and ECG is not a routine in pediatric age group, but recommendation says that it's better to have a ECG in the neonate to rule out a congenital long QT syndrome. Echo only in the case of congenital heart disease. Child with URI. This is a very important problem that anesthesiologists face day-to-day practice. They should balance the risk of surgery with the pressure of the surgeons to go about with the elective surgery. So the decision making is very crucial. So what is URI? URI, upper respiratory tract infection. It is very common in the children. Usually in the infants, it will be around 6 to 8 episodes per year. So we cannot avoid a URI. So URI is important because the bronchial hyperactivity in URI may persist for 6 weeks or longer. Mild URI is defined as the presence of clear rhinorrhea and dry cough, whereas severe URI is defined as the presence of productive cough, green running nose, and fever. So if there is a severe URI, you postpone the case. So what is the recommendation? The recommendation states that there should be a lag time of 2 weeks between the resolution of the symptoms and posting the case for surgery. Why should you postpone a case of URI? Severe URI case should be postponed because the pediatric age group are more vulnerable to the perioperative respiratory adverse event than adult population. So what do you mean by the perioperative respiratory adverse event includes laryngospasm, bronchospasm, atelectasis, pneumonia, and desaturation, which increases the morbidity and mortality. This is the latest recommendation of how to proceed with the URI. This is given in the Miller. So Miller says, if the patient presents with a mild cold, then you can proceed with the case with the pre-treatment with salbutamol. And if the patient has a moderate cold, you have to weigh the risk-benefit ratio. If the risk is more, like if the child is less than 1 year, there is a pulmonary comorbidity, airway ENT surgery, and you are going for a general anesthesia with the endotracheal intubation, then you have to pre-treat with salbutamol and proceed. Suppose the patient is having a severe URI, it better to postpone the surgery for more than 2 weeks, re-evaluate the case, and then post the surgery. In a patient with a moderate cold, but the surgery is definitely indicated because in some of the cases, the URI is a manifestation of the underlying disease, like ENT surgery, like adenoid tonsil, etc. In that case, you have to take the risk and go about the surgery. Preparation of the child. The preparation of the child for the anesthesia is very important, both for the anesthesiologist and the pediatric age group. Preparation starts with the psychological preparation, the optimization of medical problem, fasting guidelines, informed consent, IV access, aspiration prophylaxis, antibiotics, and steroids. Psychological preparation. The anesthesiologist during the pre-op visit to have to consider the cognitive function of the child, the developmental age of the child, and you have to converse in the age-appropriate language to allay the anxiety and take into consideration the dynamics of the patient family. For example, children between 1 to 3 years expect comforting rather than conversation, whereas children more than 4 years need explanation from the doctors. So there are many aids to psychological preparation, like pre-op tours to the operation theater, play therapy, videos, music therapy, etc. In the preparation, the fasting guidelines are more important. The child is more prone to dehydration if there is a prolonged starvation, and also hypoglycemia, metabolic acidosis, and cardiovascular instability. So the fasting guidelines need to be clearly followed to prevent all these side effects. Commonly, we use the 642 rule, which will be given in the next table. So the fasting guidelines says clear liquids up to 2 hours, breast milk up to 4 hours, infant formula up to 6 hours, and solids 8 hours. What is clear liquid? Clear liquid is nothing but fruit juices without pulp, flat cola, carbonated beverages, and sugar water. So you can give up to 10 ml per kg of clear liquids for the pediatric age group. Informed consent in pediatrics. Informed consent by the patient in a non-verbalizing child is not possible, and informed consent is got only from the parents. So the parent should be explained thoroughly about the procedure and the subsequent steps involved in the procedure. So you have to give the options available for the general anesthesia or regional anesthesia, detailed description of the procedure, options for post-op pain relief. The anesthesia risk should be explained in clear terms, but in a reassuring manner, not in a manner that unduly frightens the child or parent. Pre-anesthetic preparation includes IV access also. So you have to note, all the postgraduates should have the habit of noting the IV access in the case sheet, and if there is a difficulty, that should also be mentioned in the case sheet. Topical anesthetist, what are the options available for topical anesthetics? The commonly used is EMLA cream. The others are Amtop, ELA, MTX, and Escaine patch. The EMLA is nothing but lignocaine and prilocaine as a 2.5% strength, applied as an occlusive dressing 1 hour before. The other local anesthetic available is tetracaine and the combination of eutectic mixture of lignocaine and tetracaine, that is Escaine patch. But these are not available in India. So we all know that the pediatric age group fear the needles and the pain due to IV access. So regularly this EMLA cream can be used for IV access. The important step is the optimization of comorbids. If the child has a cardiac respiratory problems, fluid electrolyte abnormalities, the presence of seizure disorders on medications, you have to optimize the case before taking up the child for surgery. Preoperative consultation with other specialists, if warranted, may go a long way in helping to optimize the child correctly during the preoperative period. So coming to the pre-op transfusion, anemia is very rare in the pediatric age group, but for the completion sake, I have given hemoglobin of 10 grams is necessary for elective surgery, and pre-op transfusion is indicated only if the hemoglobin is less than 6 grams or the hepatocrit is less than 24 grams with signs of anemia in children more than 4 months of age without a cardiopulmonary disease. So what are the next is aspiration prophylaxis, which is a part and parcel of the preparation. So aspiration pneumonia, the incidence is 1 in 1,163 to 1 in 10,000. It usually occurs during induction in pediatric age group, unlike in adults, where it occurs during emergence. In pediatric anesthesia, in elective surgeries, the risk is very less, whereas it is very high in emergency surgery. So some of the risk factors are given, like emergency surgery, ASA grade 3 and 4, esophagogastric abnormality, raised ECT, obesity, coughing and gagging during intubation due to inadequate paralysis. In elective surgery, this is one of the important cause for aspiration during induction. And overall, the skill of the anesthetist also matters very much. The breast milk, if aspirated, may cause a significant pulmonary injury due to its high fat content. So for the postgraduates, the message is breast milk is not considered as a clear fluid. And the clear fluid is safe because even if it is aspirated, there is no sequelae and it's apparent within 2 hours. Mortality is very, very less, 0 to 1 in 50,000. Aspiration prophylaxis can also be given in children with high risk in the form of antacid. Is available as bicitrate, that is sodium citrate, in the dose of 0.5 to 1 ml per kg, metoclopramide 0.1 to 0.15 milligram per kg, ranitidine in the dose of 2.5 milligram per kg. Antacid should be given 30 to 60 minutes before the induction, and if you are giving a metoclopramide and ranitidine IV, it should be given 1 to 2 minutes before the induction. Pre-medication. So the most important step in pediatric anesthesia is pre-medication. The general principles of pre-medication is to allay the anxiety, to block autonomic reflexes, to reduce airway secretion, to produce amnesia, to provide prophylaxis against pulmonary aspiration of gastric contents, to facilitate induction of anesthesia, if necessary, provide analgesia. In addition, it may also decrease stress response to anesthesia and prevent cardiac arrhythmias. The factors to be considered during pre-medication is child's age, the ideal body weight, the drug history, the allergic status, child's underlying medical and surgical condition, the child's emotional maturity, personality, anxiety level, cooperation, and psychological status. A lot of routes are available for pre-anesthetic pre-medication, like oral, rectal, intramuscular, intravenous, intranasal, transmucosal, sublingual, etc. The route of administration should be selected depending on the child and depending on the type of surgery, etc. It's very important, as effective pre-medication depends on the drug, the route of administration, the desired effect, and the psychological impact of the route of administration. Anticholinergics were the mainstay of drugs in the pre-medication. It has got an anti-secretory effect, a vagolytic effect. It is usually administered to prevent unwanted autonomic vagal reflexes or bradycardia associated with the airway instrumentation, nasopharyngeal stimulation, and anesthetic drugs. The commonly used drugs are, we know, atropine, glycopyrrolate. Scopolamine is rarely used. It's not used in our setup. So the dose of atropine is 0.02 milligram per kg. And in infants, the dose should be slightly escalated to 0.03 milligram per kg. And glycopyrrolate, the dose is 0.01 milligram per kg. The side effects of anticholinergics are, as we all know, dry mouth, tachycardia, skin erythema, and hypothermia. And atropine and scopolamine may cross blood-brain barrier, produce CNS effects. So nowadays, we are not giving pre-medication with anticholinergics pre-operatively. So always now it's given as an IV after IV access is established. So need not be given pre-operatively, can be given as IV after IV access. Barbiturates, these are only for completion's sake. It is not used any longer. The oldest medication, the two drugs which were used is methotrexate and thiopentol. Methotrexate can be used as rectal or intramuscular. Rectal in the dose of 20 to 40 milligram per kg as 10% solution, and IM as 5% solution in the dose of 10 milligram per kg. Thiopentol is can be used as a rectal pre-medicant in the dose of 20 to 40 milligram per kg as a 10% solution. The disadvantage is hyperalgesia. Coming to opioids, opioids were the mainstay before the advent of other drugs. This includes morphine, pethidine, fentanyl, and sulfentanyl. Morphine was given as intramuscular in the dose of 0.1 to 0.2 milligram per kg. Pethidine rarely used in the dose of 1 to 2 milligram per kg. Fentanyl is available as both oral and nasal form. Oral transmucosal fentanyl can be given in the dose of 10 to 15 microgram per kg, but it has not gained popularity as a pre-medicant. Nasal fentanyl can be given in the dose of 1 to 2 microgram per kg, but it is not available in India. Sufentanil is a popular drug overseas, not available in India. It can be given in the dose of 1 to 3 microgram per kg. The opioids are unpopular due to postoperative nausea, vomiting, respiratory depression, and dysphoria. Coming to the hypnotics, the drug of choice or the gold standard for pre-medication in pediatric age group is midazolam. That is oral midazolam. Oral midazolam is highly effective in attenuating anxiety, increasing cooperation, diminishing antegrade recall without affecting retrograde memory. The midazolam oral formulation is available as 2 mg per ml strawberry flavored syrup. The dose of oral midazolam is 0.5 mg per kg, ranging from 0.25 to 0.75 mg per kg. The onset is about 10 to 15 minutes after oral administration. It is safe, effective, and reliable. As previously thought, midazolam does not prolong recovery, and actually the recovery is very smooth with midazolam. The only disadvantage is hiccup, which is very, very rare in 1% of the population. Midazolam can be given as IM, nasal, rectal, sublingual also. So IM midazolam can be given in the dose of 0.2 to 0.3 mg per kg in a 0.5 ml volume. The disadvantage is a burning in sensation. Nasal midazolam, preservative-free, can be given in the dose of 0.2 to 0.3 mg per kg. It has a faster onset of 10 to 12 minutes. Advantage of nasal midazolam is in pediatric age group without IV access. Again, the disadvantage is irritant and a burning aftertaste. Rectal midazolam can be given in the dose of 0.5 to 1 mg per kg, and sublingual midazolam in the dose of 0.2 mg per kg. This is the commonly used drug for pre-medication in the pediatric age group. The other two drugs, which are new drugs used in pediatric population, is clonidine and dexmedetomidine, alpha-2 agonist. Clonidine, as we all know, has both the central and peripheral action. Clonidine can also be used orally in the older children in the pediatric age group in the dose of 2 to 4 microgram per kg, 60 minutes before induction. The advantage of clonidine is it decreases the dose of induction agent like thiopentone and inhalation agent like sevoflurane. The analgesia of clonidine extends into the postoperative period, and there is an absence of respiratory depression and decreased incidence of emergence delirium. So a lot of advantage with clonidine. The disadvantage with clonidine is it has a slow onset of about 45 minutes and prolonged duration of action. Dexmedetomidine also is nowadays used in the pediatric age group. It has got a 8-fold greater affinity for alpha-2 receptors. It is used mainly as an intranasal formulation in the dose of 1 to 2 microgram per kg, 45 minutes prior. This dexmedetomidine can be combined with ketamine also. For example, you can give a oral ketamine 3 mg per kg and simultaneously intranasal dexam 2 microgram per kg. These are additive and will effectively pre-medicate the child. Coming to the ketamine, the well-known ketamine can be given as oral, rectal, nasal, IM, and IV. Usually, the oral ketamine is popular in pediatric age group. It is given in the dose of 3 to 6 mg per kg. The onset is 10 to 12 minutes. So, very fast onset through the oral route. The rectal dose is 6 to 10 mg per kg. The onset is 30 minutes. And nasal ketamine is also available in the dose of, it can 3 mg to a maximum 6 mg per kg. The onset is slow. Actually, nasal takes about 20 to 30 minutes to act. IM ketamine is also used as a popular pre-medication drugs in the dose of 2 to 10 mg per kg. The fastest acting 3 to 5 minutes. Pre-medication, low dose of 2 mg per kg can be used to facilitate mask induction in the cognitively impaired children. Then ketamine can also be used as a combination with midazolam in the dose of 3 milligram per kg plus midazolam 0.5 milligram per kg mixed in a flavored honey or any fruit juice. This is a popular pre-medication drug, ketamine, oral ketamine with oral midazolam in the dose of 3 milligram per kg and 0.5 milligram per kg. The disadvantage with ketamine is hypersalivation, hallucination, and emergence delirium. Non-barbiturate sedatives like chloral hydrate and triclofas are used in the periphery. They have a slow onset and long acting. It is converted in trichloroethanol with a half-life of 9 hours. That's why it is long acting. The dose is 50 to 100 milligram per kg to a maximum of 2 gram. It should be given 1.5 to 2 hours before anesthesia. It is safe, effective, and reliable. But the disadvantage with these drugs is unreliable, prolonged duration of action, and unpleasant and irritant to the GIT. So it is not used by anesthesiologists. It's preferred by non-anesthesiologists for sedation of pediatric age group and is contraindicated in the neonates. The other drugs which are used is tramadol, codeine, and antihistamines. Tramadol can be used as an oral or IV in the same dose of 1.5 milligram per kg, but the disadvantage is a severe post-operative nausea, vomiting. Codeine is a drug exclusively used in the pediatric age group. It can be used oral or IM in the dose of 0.5 to 1.5 milligram per kg. The half-life is 2.5 to 3 hours and the onset is 20 minutes. Rarely the antihistaminics are used. Hydroxyzine and diphenhydramine are the most two popular drugs. Hydroxyzine is used in the dose of 0.5 to 1 milligram per kg IM in hyperkinetic children. Diphenhydramine can be used orally, that is the advantage, 2.5 to 5 milligram per kg in addition to IM and IV. These antihistaminics can be combined with midazolam also. Analgesics can be given. The popular drug is acetaminophen, which can be given preoperatively as a suppository or oral before induction. The oral dose is 40 milligram per kg followed by 20 milligram per kg per oral every 6 hours, or rectal 40 to 60 milligram per kg before induction. The total dose should be 100 milligram per kg. Routinely, we are using this acetaminophen before induction. The suppository should be kept prior to induction before shifting the patient into the OT. So after seeing all the group of drugs, which is the best agent for pre-medication in pediatric age group? No single drug or combination of drugs has been found to be ideal for all children because there is a wide variation in response to sedatives in different age group. So it is up to the anesthesiologist to select the pre-medication drugs according to the patient's age group and according to the type of surgery. So the most important factors to be considered is the previous anesthetic experience, if any, and the route of administration. Steroids and antibiotics, this also comes under preparation. If the child is on chronic steroid therapy, it is better to give a stress dose of steroids in the form of hydrocortisone or dexamethasone, especially for pediatric age group with childhood asthma. Hydrocortisone, the dose is 1 to 2 milligram per kg IM or IV, or dexamethasone in the dose of 0.05 to 0.1 milligram per kg 1 hour before induction. Likewise, antibiotics, it's preferable to give antibiotics 1 hour before or IV just prior to induction. But be cautious in giving antibiotics because in some children, it may produce allergic reaction. So the ultimate goal of pre-medication is each child should be individualized and pre-medication should be customized. Pre-medication without a needle will be more pleasant for the children, parents, and the medical staff. So the carry home message is each child should be individualized and a customized plan should be adopted. Investigation within 6 months should be repeated only if the clinical condition indicate there are changes that support new tests. Pre-operative discussion with the surgeon and the child pediatrician should be done when medical records are not available. This is very helpful for the anesthesiologist to plan the anesthesia. Again, as I have said, no single drug or combination of drug has found to be ideal for all children. It should be individualized. Ensure adequate starvation and if prolonged, start appropriate IV fluids. The child should never be trusted to fast and always be suspicious. So if a child comes smiling to the theater, always suspect that the child has been fed because the attenders may change every 6 hours or 10 hours. So all the pediatric anesthesiologist should always be suspicious and ensure that the child is starved strictly. When one congenital anomaly exists, there is always the likelihood of anomalies involving other organs, and so search for it. Informed consent is mandatory, and the possibility of allergic or unusual response during anesthesia should be well explained to the parents. Review all organs with specific emphasis on the organ system involved, and routine predictors of difficulty airway are not extrapolated to pediatric age group. The next point is that in the presence of coexisting medical problems, elective surgery planned only in the best possible physical condition. Preoperative preparation and pre-medication will aid in smooth induction and recovery and avoids post-op maladaptive behavior. And when giving pre-medication, it should be given in a safe environment where resuscitation facilities are available. And the sedated child should be appropriately monitored all the times. Preservative-free drug only should be used for intranasal application to prevent CNS toxicity. And last but not the least, skill and experience of the anesthetist plays a major role in the outcome of any anesthesia. Thank you. I thank Professor Edward Johnson, sir, for giving me this opportunity on the online anesthesia platform to deliver the PG pediatric anesthesia series. Thank you, one and all.
Thank you, madam. You nicely emphasized that a child coming with a smiling face, you always suspect about the starvation.
Yes,
right,
yes.
madam.
Yes,
Over to you, Sandhini, madam. Take up 3 questions. Sandhini, madam. Unmute yourself. Unmute yourself. Sandhini, madam, unmute yourself. You are not audible. Sandhini, madam, you unmute. Sandhini, madam, you unmute yourself.
Yes.
Yes, please carry on.
Thank you, ma'am. I just have a doubt to be cleared, ma'am.
Yes.
Instead of giving Dexmed nasally and ketamine IV, can't intranasal mixed solution of ketamine and Dexmed can be administered, no, ma'am? Instead of
No. You cannot mix.
Maidora, why is it so, ma'am?
Come on.
Why is it so, ma'am?
No, you are asking whether this dexmedetomine intranasal and ketamine can be given together.
Ketamine and Dexmed together intranasally, can it be given, ma'am?
No, actually, there is no textbook description of that, but I also don't have experience with that. So some seniors can elaborate on that. I have never used like that, so I cannot comment on that.
That question is from Naresh Paliwal. He has asked. Okay, you carry on.
Thank you, ma'am. Due to shortage of time, I'll move on with the next topic. Now I invite our next speaker, Professor Dr. R. Mala, ma'am, to share her knowledge on cardiorespiratory physiology of pediatrics. She is presently the HOD and Professor of Department of Anesthesia, Stanley Medical College. She is a former HOD in Anesthesia Department at Viluppuram and Chengalpattu Medical College. Over to you, ma'am.
You can unmute yourself, madam.
Yes, I've unmuted.
Okay.
Start the slideshow.
Yes, start please.
Good morning, all. First of all, I would like to thank the team of this online anesthesia headed by Dr. Edward Johnson for giving me this opportunity. Now I'll go to my presentation. So my topic is about pediatric respiratory and cardiac physiology. So there are certain definitions concerned to understand about the pediatric population. Neonate is first 4 weeks of life. Premature infant is less than 37 weeks of gestation age. Infancy is up to 12 months. Low birth weight is less than 2.5 kgs. And there are some more subdivisions in this low birth weight, very severe low birth weight and all that. So for our understanding, let it be low birth weight less than 2.5 kgs. Chronological ages, time since birth in weeks or months. Now we'll go to the respiratory physiology, the developmental physiology. First, we will see the various stages of development in the fetus itself. So the lung development passes through 5 phases that overlap. Each stage is designed for more maturation and further structural development. It starts early in gestation, goes through childhood. There are different stages like embryonic, pseudoglandular, canalicular, saccular, alveolar stages. How to reduce this side view, sir?
It is full screen, madam. Slide is okay.
Okay, I'll reduce this.
Okay.
So lung development passes through 5 phases, as I told you. Now, the first phase is between 3 to 7 weeks. When there is formation of lung bud and initial dichotomous divisions of the airways. This starts at 25 days in fetus as a foregut derivative. Laryngotracheal grooves form in the ventral foregut and lung bud separates and pleuroperitoneal folds form, and peritoneum goes separately, and the lung bud starts developing individually. 5 from primordial lung lobes form, 2 left and 3 right lobes. The failure of lung bud to differentiate happens at this stage. This is known as pulmonary agenesis. This happens more in the right lung. Then the pleuroperitoneal folds closer and the vascular channel starts developing. So next is pseudoglandular phase. This goes between 7 to 16 weeks. Segmental and subsegmental bronchi develop, and there is appearance of bronchial vessels from the 8th week onwards, and airway epithelium starts differentiating, and muscle components also starts developing. Airway diameter increases and also the length increases 2 to 3 fold. And this goes on increasing between birth and adulthood. Large airways stop branching after 16 weeks. Then the next stage is canalicular phase. This goes on from 16 weeks to 26 weeks. The conducting airways, they develop up to the respiratory bronchioles. This conducting airways contain this cartilaginous support only up to large terminal bronchial level. Beyond that, there is no cartilaginous support. Clara cells start developing. What are these Clara cells? These are non-ciliated bronchial secretory cells. They are secretory in nature. They also form a progenitor cell for repairing this bronchial epithelial cells. Then there is muscularization of pre-acinar and resistance arteries, and branching of airways happens. That is up to respiratory bronchial level. And at the end of this 26 weeks, we have 23 airway subdivisions already developed. Saccular phase up to 48 weeks. From 24th week, there is a differentiation of acinar epithelium. Surfactant production starts. This is an important component in this stage. There is initiation of lung fluid absorption, which is very important for the lung expansion at birth, because the preparatory phase starts for fluid absorption. Then alveolo-capillary membrane thickness is about 0.6 micrometer. This is enough to participate in gas exchange. This thickness is enough, and this thickness is already developed at 24 to 48 weeks. Then there is widening of alveolar sacs. So gas exchange area increases to prepare the child for gas exchange. Then alveolar phase. This is the final stage initiated in the fetal lung development, and this starts from 36 weeks and goes on up to 18 months postnatal. This is set to establish the large surface area involved in gas exchange. 20-fold increase in surface area happens from 50 million to 300 million alveoli form. There is formation of primary and secondary alveoli, formation of secondary crests. This will help in the formation of clusters of alveoli. So the number of alveoli increases. Also, there is septation of airways with elastin deposition. This elastin deposition in the later stages helps in the compliance of peripheral airways. Then development of pores of Kohn. They are interalveolar pores which help to maintain the gaseous continuity between acini, and also they help in preventing the collapse of alveoli. Then there is formation of secondary crest. Then this alveolarization is incomplete at birth, but gets completed only by 3 years of age. Then this development of chest wall and diaphragm starts in the 4th week. This lateral body folds, which are comprising of lateral plate mesoderm and which are covered by ectoderm, they move ventrally to meet in the midline to form the chest wall. And sternum starts developing, and it develops from the mesenchymal folds, which are parallel to each other, and they are like plates, and they condense and fuse in the 10th week. Then formation of cartilage starts immediately in this sternal plate, but ossification will begin only after the 6th month after birth. Then ossification of the ribs starts from 7th week of gestation to early adulthood. Diaphragm formation starts happening after 7th week. Failure of diaphragm formation leads to the peritoneal contents moving into the thoracic cavity, and there is pulmonary hypoplasia of ipsilateral lung, and due to mediastinal shift, due to the movement of contents into the peritoneal cavity, the contralateral tongue also gets affected. Then pulmonary vasculature. Vasculogenesis and angiogenesis. Vasculogenesis is branching of vasculatory. Angiogenesis is formation of endothelial cells, starts from the canalicular stage itself. Bronchial circulatory system, which is the second circulatory system present in the lungs, starts from 8 weeks. Microvascular maturation happens. Expansion of air space surface area happens. Interstitial tissue volume also increases. Lung volume increases to 23-fold. Capillary volume increases by 35 folds. Muscularization of vasculature happens. If there is abnormal extension of smooth muscle in arterioles, there is primary pulmonary hypertension and severe bronchopulmonary dysplasia. So only the development of vasculature helps the pulmonary alveolar development also. Now we see the physiology and anatomy of upper and lower airways. Nasal breathing is very important for neonates. They are obligatory nasal breathers. There is increased nasal resistance up to 3 years. So any nasal congestion due to secretions, mucus or blood will create problem for the newborns, neonates breathing. So the reasons for this will be large tongue, cranially positioned epiglottis, and this epiglottis, because it is big and it is seems to be in contact with soft palate. So all these contribute to nasal breathing in the neonates. And also there is high upper airway complaints due to low muscle tone and higher flaccidity of supporting cartilage. So any distress makes the child develop airway collapse due to forceful inspirations. So the child can easily go into a sort of upper airway obstruction due to airway collapse and low muscle tone. And also forceful expiration. Airway collapse happens due to compressive force of the thorax and respiratory muscles, which happens during crying. And also smaller airways in neonates. There is increased airway resistance because 50% of the airway resistance is contributed by small airways. In contrast to adults, where the peripheral airways contribute only to 20% of airway resistance. About chest wall and respiratory muscles, diaphragm is the principal muscle in respiration as far as infant and neonates are concerned. Diaphragm is horizontally placed, which decreases the efficiency of breathing. And also the costodiaphragmatic angle is shallow. So it is unable to increase the tidal volume when required in moments of stress. Diaphragmatic respiration is the principal respiration. And if there is splinting of diaphragm due to any abdominal distension, it adds to the respiratory distress and inefficiency. So the children can easily go for respiratory fatigue because diaphragm has more of less of fatigue resistant type 1 muscle fibers. So with the in addition, there is less efficient intercostal muscles. So in inspiration, diaphragm contributes more to the inspiratory activity. This is in addition to the less efficient intercostal muscles. They make the child prone to respiratory fatigue. and contribution of external intercostal muscle is less in inspiration. So we should always anticipate this problem in the post-op phase, where there is already weak muscle contribution to respiration. In addition to the anesthetic agents, baby can further go for reduction of FRC, airway collapse, and they are also more prone for apnea also. So all this together, they can easily go for hypoxic status. At the end of first year, this muscular component reaches a level almost similar to older children and adults. About the chest wall, cross-sectional area of thorax is square shaped, where AP diameter and the lateral diameter is almost equal. Ribs are horizontally placed, and this limits the function of intercostals. By 10 years, all this will reach the adult configuration. There is more downward sloping of the ribs, with the bucket handle movement becoming more efficient, and there is more increase in the intrathoracic volume. More negative pressure is able to be generated with the development of these ribs and intercostal muscles. The efficiency of respiration is improved. Then there is high chest wall compliance and increased deformability. So during respiratory distress, the chest easily undergoes distortion. Energy is getting wasted to improve the efficiency of respiration, because already chest deformability is there. So adding all this, there will be reduced efficiency of breathing during respiratory distress. This makes the child, as I told you again, prone to respiratory fatigue, and they can easily go for respiratory failure. Ossification of ribs decreases the chest wall compliance slowly. Then about lung fluid physiology. The rate of formation of lung fluid is about 4 to 6 ml per kg per hour. Near birth, lungs are filled with almost 20 to 30 ml per kg of fluid, which is equivalent to functional residual capacity of the child. More chloride content is there due to active secretion by the tracheal and distal pulmonary epithelium. This is more when compared to amniotic fluid also. And fetal lung secretion is enhanced by prolactin, keratinocyte growth factor, and prostaglandins, E2 and F2, which are secreted in abundance from placenta. And this lung fluid secretion is inhibited by beta agonists, vasopressin, serotonin, and glucagon. This is the presence of fluid, if it is present in more quantities, becomes an obstacle to air breathing. So fetal lung fluid is removed by absorption, bulk removal, and maturation of surfactant nearing term. So the epithelium, which has been secretory, now becomes absorptive towards term. There is induction of components of epithelial sodium channels around the time of birth, which increase the intracellular cyclic AMP levels, like beta agonists, phosphodiesterase inhibitors, cyclic AMP analogs. Glucocorticoids and thyroid hormones also do the same function. They prime the lung epithelium to the action of beta agonists. Then hormones, through catecholamine induction, also clear the fluid during normal delivery. Air breathing and increased intrathoracic negative pressure promote clearance into the interstitial tissues just at the time of delivery of the child. So the residual liquid in lung after transition is about 0.37 ml from the initial larger amounts. So what are the cell types that are present in the lungs? In the proximal airways, ciliated epithelial cells are present. Main function is to clear the mucus. Mucus producing goblet cells are seen from 13 weeks. They protect lung from foreign material. Cartilaginous support of tracheobronchial tree starts from trachea in 4 weeks to terminal bronchioles at 25 weeks of gestation. Muscular investment of the airway starts from 68 weeks and goes up to terminal bronchioles, and it is reactive. It is shown to be reactive in the first trimester itself. Then pulmonary neuroendocrine cells, which secrete amine and borbacin, they control the bronchial tone. They have major role to play in sudden infant death syndrome, bronchopulmonary dysplasia, then pulmonary hypertension, cystic fibrosis, in all these conditions. About the cells in distal airways, there are fewer ciliated cells and goblet cells in the distal airways, but Clara cells are there. They are abundant in the terminal bronchioles from 16 to 17 weeks, and there is a dramatic rise in the numbers in distal bronchioles by 24 weeks. They have an important part to play in host defense, detoxification of inhaled air, high level of cytochrome P450 and flavin monooxygenase are present in them, and they have a role to play in immunoregulation of distal airways, and they also moderate protease and anti-protease balance in the lung. The main function is but host defense and detoxification of inhaled air. Then about the cell type in alveoli, epithelial lining of alveoli begin to differentiate into type 2 and type 1 cells. They start forming in the saccular phase itself. Type 1 cells participate mainly in the gas exchange. They provide an absorptive surface for water and ions. Type 2 cells form surfactant mainly. They are packed with granules containing surfactant, phospholipids, and proteins. They have specialized ion and water channels in the membranes lining them, and they participate in detoxification and sterilization of the alveolar microenvironment. They participate in coagulation fibrinolysis cascade. They are a source of cytokine and chemokine production also. Then about surfactant, which is essential for alveolar health. Before 28 to 32 weeks, lungs are unable to retain any air. They are in a collapse state. The surface tension, which is operating at air fluid interface in the thin liquid layer lining the alveolar epithelium, opposes the alveolar inflation and always keeps the alveoli collapsed. So surfactant has to antagonize this effect of the surface tension. By 24 to 28 weeks, surfactant lowers the surface tension, gives good elasticity to the interface, air fluid interface, and tries to maintain FRC by keeping the alveoli open. And this prevents alveolar collapse and prevents end expiratory atelectasis and lowers the force. This is which is required for subsequent alveolar inflation at birth. This is the main function of surfactant. In fact, surfactant is preparing the baby's lungs for first breath and inflation. Initially, it is secreted in low quantities. Later on, it increases towards gestation, and the deficiency of surfactant leads to respiratory distress syndrome. And surfactant's composition is 80% phospholipids, lipids 10%, and proteins 10%. Dipalmitoyl phosphatidylcholine is the only surface active component of this lung surfactant. This is modulated by, the secretion of surfactant is modulated by glucocorticoid. That is why we administer glucocorticoids, beta agonists, or tocolytic, terbutaline, at the time of labor in women undergoing preterm labor. In physiological changes in lung lipid and blood flow at birth, in fetal life, placenta helps in gas exchange. Fetal oxygen tension, that is partial pressure of oxygen tension, is almost constant in spite of the variation in maternal oxygen levels. The critical events at birth will be hypoxia, hypercapnia, and with the increased sensitivity of chemoreceptors, initiate the first breath in the newborn, and lung fluid starts clearing. Part is extruded from the mouth also. As I told you, part of it goes through lymphatics and interstitium. Intrapleural negative pressure, which is required for the first breath, is very high. That is 40 to 100 centimeter of water, which is because of the low compliance of the newborn lung. Initially, newborn lung has very low compliance. It starts increasing to 6 ml per centimeter of water, and slowly, as the compliance increases, the resistance to airflow also decreases. Then this retained lung fluid sometimes may cause minimal quantities of retained lung fluid. If the baby is born through cesarean section, not that labor has gone through the normal phases and normal delivery, if it doesn't happen, sometimes there is some amount of retained lung fluid in the, which is causing transient tachypnea of the newborn. So this transient tachypnea, as the name suggests, reaches a maximum by 24 to 48 hours, and the appearance almost mimics fluid load or pulmonary edema, and completely resolves. There is a total resolution by 72 hours. And if it is accompanied by some other factors like meconium aspiration or any lack of surfactant, there is a reversion to fetal circulation with increased right heart pressures, and sometimes there is persistent fetal circulation also. The other terminology being primary pulmonary hypertension, where there is increased right heart pressures, right left shunt, and the final even being hypoxia. About a word on ductus arteriosus in premature infants. Ductus arteriosus in premature infants is thin and it lacks the muscle component. So it doesn't become hypoxic with constriction as in a fully developed ductus in a term infant. So there is some amount of luminal blood flow that is happening, and so there is a delayed anatomical closure in this ductus. So when we use surfactant therapy in this premature infants, along with ventilatory management, when there is a decrease in pulmonary vascular resistance and with the increase in systemic vascular resistance, the resistance that already has happened after birth, there is a reversion of pressures. So there is a left to right shunt that is happening in these children with the treatment with surfactant. So in this condition, we can expect pulmonary edema. In addition, there may be steel mechanism which is going to cause intraventricular hemorrhage or bowel ischemia. So these things have varied pathology in addition to the pathology that is happening in the lungs due to the prematurity. So the treatment attempted is with the prostaglandin inhibitors, indomethacin or ibuprofen. If they do not respond, the condition is worsening, baby has to be subjected to surgical ligation through thoracotomy. Then lung development after birth. The phases still continue. Alveolar phase extends up to 2 years, continues to teenage years. Microvascular maturation continues up to 3 years. Initially, the capillary network is a folding of capillary network on itself. So it will be double layered. Later on, as the alveoli expand, interstitium becomes thin and the capillary network becomes a single layered. After 3 years, there is increase in the size of alveoli, increase the lung surface area, and also the lung expansion becomes proportionate to the body weight of the child. Bulk alveolarization happens from the first month of postnatal life due to the early formation of secondary crest with the clusters of alveoli forming, and completion of cartilage formation also continues. There is late alveolarization. This adds the alveoli in the subpleural regions of the lung. Then control of breathing. In premature and mature infants, also there is immature breathing. Irregular and periodic pattern is seen in both premature and mature infants. Immature infants also show other features. There is other mechanisms of immaturity like peripheral central chemoreceptor responses are immature brainstem respiratory rhythmogenesis, and there is risk of apnea. So this has to be taken into consideration when we plan anesthesia for these infants. And the ventilatory response to hypercapnia. In hypercapnia, there is increased respiratory rate and tidal volume. This response is seen in term infants, children and adults. But this kind of response will not be seen in preterm infants. So preterm infants, there will not be any response, there is simple apnea. In ventilatory response to hypoxia, in preterm infants, it shows a biphasic response, initial ventilation, increased ventilation for 1 minute followed by diminished ventilation apnea. Whereas in other category like term infants, children and adults, it is only a stimulation of ventilation. Other mechanisms for apnea apart from the immature breathing immature respiratory centers and chemoreceptor response, the other mechanism will be exaggerated inhibitor response to apparent laryngeal stimulation or excessive lung inflation through the operation of Herring-Brewer inflation reflex. So pulmonary stretch receptors are activated and the efferent response being apnea. So this kind of response is more pronounced in infants compared to older children. So these mechanisms also operate to establish apnea in infants. Preterm infants have propensity to develop both central as well as obstructive apnea. In central apnea, there is no respiratory effort. In obstructive apnea, there is the presence of respiratory effort, but there is obstructive pattern. That is, the obstruction could be, the main side could be the pharyngeal muscles due to reduced muscle tone. So the treatment, this has to be recognized, and treatment will be respiratory stimulants like caffeine, or if not responding, they have to be managed with CPAP and mechanical ventilation. Then pulmonary function testing. Pulmonary function testing is subjective, and the results may be inconsistent. So single point measurement also are of limited value as diagnostic and prognostic tool, but arterial pH, there's no variation with age. But in babies who are being treated on ventilators in ICU setup, we can make measurements on a day-to-day basis or as and when needed, and we can get the parameters and make ventilatory settings and treat the babies. Otherwise, we have to go with the predicted values with reference values only because of subjective variation. So the pulmonary function in infants, the parameters are the compliance. In infant, the compliance is about 1.5 to 2 ml, whereas in child it is 2.5, and in adults it is 0.1 1 liter per centimeter of water only. Compliance is more in infant and child. Airway resistance is about 20 to 40 centimeter of water per liter per second, whereas in adult it is very less only. FRC is 20 to 25 ml per kg, and in adult it is about 1.9 to 2.4 liter. Tidal volume is about 4 to 8 ml per kg, and in adult it is 6 to 8 ml per kg. Respiratory rate in the infant is 20 to 60 breaths, adult it is 12 to 20 breaths. Minute volume per kg body weight is more in infant compared to adults. Oxygen consumption is also more compared to adults, 7 ml per kg per minute. Compliance is the change in volume per unit change in pressure. The total compliance is equal to lung and chest wall compliance. Both are high in infants. This predisposes to alveolar collapse, ventilation coefficient mismatch, and hypoxia. Lung compliance increases with the growth of lung, but specific compliance, that is lung compliance divided by FRC, is relatively constant in children and adults. Lung compliance mainly depends on the amount of elastic fibers and the quality of surfactant that is present. Chest wall compliance is high in infant. As I told you, this leads to ineffective breathing in moments of stress. With the ossification of rib cage, chest wall compliance comes down. Increased chest wall compliance results in lower FRC, and this almost approximates the closing capacity in infants. So there are chances of airway collapse. So to reduce airway collapse, collapse of small airways, so infants by themselves, they adopt certain compensatory mechanisms through activation of respiratory muscles in both the phases, which includes diaphragm also, and they increase the respiratory rate at the cost of the expiratory time, which keeps the airway open, and through vocal cord adduction and with higher respiratory resistance in inspiration and with lower expiratory flow, they try to maintain the patency of smaller airways at the end of expiration. These are the compensatory mechanisms. So all these compensatory mechanisms are attended by the anesthetics and the respiratory depressants that we administer. So they have to be watched for in the perioperative phase. Resistance. Airway resistance is the non-elastic airway and tissue forces resisting gas flow. So airway resistance is directly proportional to the driving pressure divided by the airflow. This is given in centimeters of water per liter per second. Poiseuille's law states the airway resistance is increases with a decrease in the airway radius. So with the reduction in the airways, the airway resistance likely to go up. So the diameter of airways in infant and children is smaller than that in adults. So 50% of contribution of airway resistance is by small peripheral airways in infants. So this is in contrast to 80 to 20% contribution by small airways in adults. So children, infancy, they are vulnerable to small airway disease like bronchiolitis. So about gas exchange, it happens across alveolo-capillary membrane. Thickness of alveolar capillary membrane is same in all ages. Surface area of gas exchange increases throughout adulthood and also increases the diffusion capacity. Pores of Kohn and canals of Lambert. Canals of Lambert are bronchoalveolar communications. They improve the gas exchange. They keep the air sacs open and prevent air sacs collapse. So they help in gas exchange. Absence of these sometimes lead to lung atelectasis, ventilation coefficient mismatch, shunting, and hypoxia. Anatomical dead space is more due to the large extrathoracic component of anatomical dead space. So the dead space to tidal volume ratio in children is more, that is 0.4 to 0.5 compared to 0.2 to 0.3. So there is more wastage of ventilation in the dead space. To compensate for this wasted ventilation, and also due to the higher metabolic rate, and also due to higher oxygen consumption. So the children has to have infant, newborn, neonate has to have more minute volume compared to adults. So now we go to cardiovascular physiology in children. There are changes abruptly happening from fetal state to transitional state, then to mature circulation. Slowly happen in, up to the later part of infancy. There are changes in circulatory pathways, change in myocardium, and autonomic control also. So during fetal circulation, there is high pulmonary vascular resistance, collapsed lungs which are filled with fluid. Oxygen is supplied only from placenta. Lungs do not take part in oxygenation. So 50, there is one umbilical vein, two umbilical arteries. 50% of umbilical venous blood that is going through the ductus venosus bypasses the liver to reach the right atrium. Then this goes to left atrium preferentially through the foramen ovale, and then reaches the LV and goes to supply the brain, myocardium, and upper part of the body. The other half of oxygenated blood goes through the liver and collects all the deoxygenated blood from the liver, and also the deoxygenated blood from the IVC and the blood that is coming through the portal vein, and joins the deoxygenated blood from the SVC also, and from the upper part of the body, and goes to the right atrium, then goes across a tricuspid valve to right ventricle, and this blood preferentially ejected bypasses the lungs due to high pulmonary vascular resistance, enters the descending aorta through the ductus arteriosus, while only 8 to 10% of the amount that is entering the RA goes to the high vascular resistance pulmonary circulation. In the fetus, the circulation runs in parallel. After birth, it becomes in series. So the part of the blood in the descending aorta supplies the lower half of the body, while the other part drains via the two umbilical arteries to placenta for reoxygenation. Thus, fetal circulation is in parallel. It is not in series as in adults. The left ventricle preferentially supplies the well-oxygenated blood to the brain, myocardium, upper part of the body, whereas the right ventricle supplies blood with lower oxygen tension to the lower half of the body and the placenta. Now the transitional circulation. So the transitional circulation changes to series from parallel. Lung inflation happens following the first cry, and there is also cutting of the placenta, removal of the placenta from the whole circulation. So lung inflation reduces the high pulmonary vascular resistance, clamping of placenta and cutting it increases the systemic vascular resistance. There is no flow through the ductus venosus now. Pulmonary blood flow is augmented and blood return to left atrium is increased, and the pressure rises in the left atrium. So there are change. There is a change in the pressure gradient in the right side and left side at pressures. Ductus venosus narrows and decreases the blood going to the right atrium. So the right atrium pressure decreases due to altered pressure gradients. Foramen ovale closes. So the blood now has to pass through the series method only. Reversal of pressure gradient between right atrium, left atrium, foramen ovale undergoes functional closure. The constriction of ductus because of rise in PaO2 and decrease in the prostaglandin level due to removal of the placenta. Now it almost goes to a functional closure. This happens within 24 to 48 hours, but anatomical closure takes about 4 to 8 weeks to happen, and finally it becomes a ligamentum arteriosum. If there is a so both the right ventricle and left ventricle outputs have become equal. In premature infants and infants with congenital heart disease, congenital diaphragmatic hernia have altered transitional physiology. They don't go through the transition smoothly, and there is an alteration in this transition phase. So transitional circulation is a temporary phase and it is vulnerable to changes. Either it may go in a normal phase to the mature circulation, or if there are any pathology, as I told you, may revert back to fetal circulation also. If there are any inadvertent increase in pulmonary vascular resistance in the peria period due to the factors which increase the pulmonary vascular resistance, they may reopen the ductus and foramen ovale and bring back the transition circulation to persistent fetal circulation. This persistent fetal circulation, if it changes to transitional circulation, is not attained it is due to hypoxia, hypercapnia, and acidosis. They are all potent vasoconstrictors and they raise the vascular resistance in the pulmonary circulation. So, if there is a persistent fetal circulation, there is an increased elevated right heart pressures. So, how to understand, how to know its presence? We can clinically, we can keep pulse oximeters, 2 pulse oximeters in the preductal and postductal area, one in the right upper limb and one in the lower limb. If the preductal level is at least 3% above the postductal level, we can assume that it is a kind of fetal circulation that is operating, and also we can confirm that there is a right to left ductal shunting is happening. So the difference should be more than 3% in the saturation when 2 pulse oximeters are kept in the right upper limb and the other in the lower limb. So right to left shunting due to persistent fetal circulation causes reduced pulmonary blood flow, reduced oxygen delivery to peripheral tissues and hypoxia. And the anesthetic implication of this right to left shunting will be there will be delayed uptake of volatile anesthetics and prolongation of inhalational induction. But if this kind of right to left shunting is there, it may hasten the IV induction. So during IV induction, there may be abrupt hemodynamic changes due to the rapidity of induction. So this has to be watched for. After this phase, adult circulation starts with further fall in the pulmonary vascular resistance. So what are the factors that affect the patency of the ductus? The patency in fetal state is maintained by low fetal oxygen tension, cyclooxygenase mediated products of arachidonic acid metabolites like prostaglandin E2 and PGI2. They are in increased amount, they are secreted by the placenta. Afterward, there is increased saturation. So there is inhibition of ductal smooth muscle potassium channels, causing calcium influx and ductal constriction. And removal of placenta reduces the levels of prostaglandin E2 and I2. And moreover, this PGE2 and I2, that is prostacyclin, is metabolized by the participation of lungs also. So all these factors cause the ductus to close. So here in this picture, we can see the saturations and pressures. In IVC, in the first picture, you can see the saturation to be 70%. And the left atrial mean pressure is 2 and mean pressure in the right atrium. The right side of pressure is more, mean pressure is 3. In the right ventricle, the pressure is 55. And the pressure is about 70/4. The saturation is 55 in the right ventricle. And in pulmonary artery, we can see the pressure. It is 70/45. Mean pressure is 55. In transitional circulation, the PA pressure comes to 50/30 and the mean pressure is 38. In the picture C, it is the mature circulation. C is mature circulation, B is transitional. In C, the mature pattern of circulation in series. Here we can see the pulmonary pressure almost equal to adult PA pressure, the mean being 18, and the ductus arteriosus is completely closed, and the saturation in aortic blood is 99%, and the pressures in the aorta have increased, and the left atrial pressure is about, mean pressure is 4, and the pulmonary vein which comes to LA gives a totally fully saturated blood. So there is a change in PVR from the fetus to the transitional to adult levels. So this is the change in the pulmonary arterial pressure from 40 millimeter of mercury to almost 10 in a matter of 3 to 5 weeks since birth. And pulmonary blood flow comes down from increases from less than 40 ml per minute per kg to almost 160 to 180 ml per minute per kg, and PVR reduces from almost 2.8 millimeter of mercury per ml per minute per kg to almost it is coming to near baseline levels. at 5 to 6 weeks after birth. So the myocardial performance. Newborn heart performs with maximal myocardial contractility due to the maximal beta stimulation by the large amount of endogenous catecholamines and thyroid hormones which have been released during labor and childbirth. To suit the high metabolic demand of oxygen, this functions at the maximal level, and resting myocardial tension is also more, and also newborn myocardium is able to develop only less stress during systole. Myocardium is less compliant or it is stiff, and because there are disorderly arrangement of myofibrils and cardiac myocytes. And the amount of non-contractile proteins is also more compared to mature myocardium. Stroke volume is almost static. It cannot increase with an increase in the preload or an increase in the left ventricular end diastolic volume or pressure. So, but cardiac output is higher, 200 ml per kg per minute, and it is mainly dependent on heart rate. Even heart rate up to 200 is well tolerated in the newborn infant. But if heart rate drops to 120 per minute, it decreases the cardiac output by 20 to 30%. So there will be bradycardia in response to hypoxia. So we have to treat only with oxygen. So they are not going to respond to atropine match. So we have to manage bradycardia only with oxygen. Newborn heart works at the highest plateau of Frank-Starling curve because of the circulating catecholamines. So they cannot tolerate a rise in systemic vascular resistance also. Even a rise in afterload is not tolerated. They can, there is a limited ability to develop much tension in the myocardium. So the stroke output cannot be improved beyond a certain limit. After that, it reaches a plateau. So the depressant effects of IV agents, volatile agents, hypoxia, hypocarbia, acidosis, electrolyte imbalance, or the depressant effects of all these are poorly tolerated by the myocardium. And there is also less response to exogenous catecholamines. And this response is restored only in the later part of infancy, when the endogenous when the catecholamines from which have been present since labor, they are reduced in the circulation. Then only the infant starts responding to exogenously administered catecholamines. So this is the length tension relationship. You can see here. This is the length tension relationship in the adult myocardium. But here in the infant's heart, this curve is reaches a plateau with a lower level of tension developing. It cannot go to this higher level of tension with the increase in the sarcomere length. So it cannot withstand even small increase in the preload, that is LA pressure, or afterload, which is mean arterial pressure. So also cannot increase the inotropic state to exogenous catecholamines. So it depends only on the heart rate to maintain the cardiac output. Because of a greater increase in the ventricular pressure to volume loading, the diastolic function is also restricted in the neonate. These are the normal values, age reference values in various levels. That is, in neonate, less than 30 days, the heart rate is almost 160. Systolic pressures are 60 to 75. Slowly, there is a change, and by 1 year, it comes to 110 to 140, and the pressures slightly go up to 85 millimeters of mercury. And by 16 years, they reach the adult pattern. About autonomic nerve system. In autonomic nerve system, the parasympathetic component is dominant, and the sympathetic component is in a developmental stage, and it shows development, and there are not much of sympathetic fibers which have developed at birth, and from 6 months and later on at 1 year, the sympathetic nerve system is well developed. So there may, because of the development that is going on, there may be variability in the maturation of autonomic nervous system. So the variations which happen in heart rate, there may be conduction artifacts, arrhythmogenic pattern in the ECG. So it has to be well correlated with the general condition of the infant, and it has to be thoroughly analyzed. Then only we can say that these are all abnormal. Unless abnormal or any congenital cardiac problems are excluded, this should not be taken as a normal variation. So the parasympathetic system is predominant at birth, and sympathetic maturation with the fibers maturing only at 1 year of age, or only after first 6 months they start to show maturation. So about oxygen carriage, newborn has more of fetal hemoglobin than adult hemoglobin. After birth, fetal hemoglobin levels start slowly coming down, and by 6 months of age, there is more of adult hemoglobin. So when there is reduced erythropoietin to produce more of adult hemoglobin, and also there is reduction in the fetal hemoglobin, and with increasing circulating blood volume, there happen to be a physiological anemia of infancy, about 9 to 12 weeks of age. So in premature infants, this anemia comes even earlier. So there is more fall in the hemoglobin level also in premature infants. All these factors have to be considered when we do a pre-anesthetic assessment in these children. Hemoglobin F has, the fetal hemoglobin has higher affinity for oxygen, but in fetal stage, oxygen delivery is compensated by the rise in 2,3 DPG levels and shift of ODC to the right. Now we'll see the major differences between neonatal and mature hearts. In physiology, the contractile state of the neonatal myocardium is of limited nature, whereas in mature heart, response and the tension and the stroke output can be increased with the increase in the initial myocyte length. Then heart rate dependence is high in neonatal myocardium, whereas it is low with mature hearts. Contractile reserve is low and it is high in mature heart. Afterload, preload cannot be tolerated well in neonate. Ventricular interdependence is significant neonate, whereas in mature heart it is less. And about calcium cycling, the predominant site of calcium flux is sarcolemma, whereas it is sarcoplasmic reticulum in mature heart. Why it is so? Because sarcoplasmic reticulum is yet to develop well in the neonate. Dependence on normal calcium is high. So that is only cytosolic calcium participates in the cardiac contraction, whereas normal calcium, the dependence on the cytosolic calcium is low in the mature heart, depends mainly on the calcium from sarcoplasmic reticulum. Then circulating catecholamines are high in neonate and they are less in adult heart. And adrenergic receptors. The quantity of adrenergic receptors are there, but same as in adults, but they are insensitive, and there are more of beta 2 and alpha 1 compared to beta 1 predominance in the mature heart. So beta 2 response is more with the neonate. Alpha 1 also responds through stimulation of myocardium, whereas here beta 1 takes the predominant stage in the mature myocardium. Then innervation, parasympathetic innervation is predominant. Here sympathetic innervation is incomplete, and in mature heart sympathetic innervation is complete. The cardiac cytoskeleton, there are more of collagen and water content. Here in mature heart, less of collagen and water content. Cell elements, the sarcoplasmic reticulum development is incomplete. There are disorganized myofibrils, whereas in mature heart, the myofibrils are organized in a parallel regular fashion. So the cardiac contractile efficiency is good, and also the sarcoplasmic reticulum is mature enough to participate in cardiac contraction. So the characteristics and their anesthetic implications will be persistent fetal circulation will cause prolonged tissue oxygen delivery and the anesthetic implication in inhalational induction and rapid IV induction. Vulnerable transitional circulation has the impact that it makes the child susceptible to revert to persistent fetal circulation perioperatively. Stiff myocardium. So it is almost static stroke volume. Stroke volume cannot be increased further. Rate dependent cardiac output. Cardiac reserve is less and cannot tolerate changes in the preload, afterload, or any myocardial depressant drugs, or it cannot tolerate hypovolemia or cannot tolerate arrhythmia. Predominant parasympathetic control of heart. So they make the child prone to bradycardia in response to noxious stimuli. There is circulation of high basal endogenous catecholamines. So exogenous catecholamines, myocardium cannot respond. Only at the end of 1 year, the response to myocardial contractile response to sympathetic stimulation is restored, and contractile response can be enhanced with exogenous catecholamine administration. Then high fetal hemoglobin in the newborn. So it makes the newborn prone to perioperative hypoxia. So important points to ponder will be in respiratory system, there is immature respiratory center, muscles are inefficient, lung mechanics is inefficient, and metabolic demand for oxygen is more. There's more of apneic spells, respiratory fatigue can occur easily. So easily they can go into respiratory deterioration. So we have to administer anesthetic agents in a proper manner and also monitor the child in the periop phase and avoid components like hypoxia, hypercapnia, acidosis, and any electrolyte disturbance. And we should make it a point that in the immediate newborn period, pulmonary vascular resistance should not change at all. And about the cardiac physiology, it's a rate-dependent cardiac output. It's a predominant parasympathetic drive, limited contractile reserve, poor tolerance to changes in preload and afterload. So we have to administer drugs. We have to titrate the drug dosages. And they should be administered carefully and slowly also, watching the effect. Bradycardia is a predominant response. So instead of administering atropine, the main thing that has to be administered, we have to ensure that oxygen is properly administered to the infants. If heart rate is less than 60, initiate external cardiac compression. They are prone to hypoxia in spite of higher hemoglobin F level due to less oxygen delivery to the tissues. The incidence of congenital heart disease is 7 to 8 per 1,000 live birth. In this, 10 to 15% will have associated non-cardiac pathology also. So any neonate, as Madam said, when it comes for pre-anesthetic assessment, we have to have an idea about all the midline defects which may be associated with cardiac lesions. We have to have an open idea to screen for all cardiac, congenital, as well as respiratory anomalies, and also thinking of the respiratory physiology and the treatment that the child has undergone as far as respiratory pathology is concerned should be taken into mind when we are giving pre-anesthetic assessment, and we have to go through the records properly so that we can plan our anesthesia. Okay, thank you. Thank you so much for giving me this opportunity.
Thank you, madam. You extensively covered the topic, madam. After watching your presentation, the postgraduate need not go and read any other books. You covered all points in your presentation, madam. Thank you so much.
Thank you, sir.
Thank you, madam. With that, we come to the end of this session. Next week, we will meet with the pediatric airway. I thank the Akrula A1logist and the Anaesthesia TV. The Akrula is going to come up with a nasal midazolam preparation next month. With that, we will conclude this session. Thank you, Ananda. Thank you, Mala madam. Thank you, Shantini madam.
Thank you, sir.
Thank you, sir.
Madam. Thank you, Mala madam.
Thank you, madam.
Thank you, ma'am. Thank you, ma'am.
Thank you, Shantini.
We will meet next week. Thank you.
Thank you, sir.
Thank you, sir.